And welcome to the quarterly treatment planning webinar sponsored by the Institute for Dental Specialists. This is an organization that is dedicated to making sure that the specialist has all of the tools that he or she needs in order to be able to succeed in today's dental environment. If you're not on our list, just send us an email. Lee@directorofdentistry.com, Lee@directorofdentistry.com, and I'll make sure you're on the list for future webinars. This is a very exciting program that we're going to have with Dr. Peter Nordland. I'm going to introduce Dr. Nordland in just a second. I want to thank our sponsors for this event. Sponsors that you may know, and they have provided a lot of support for us, for the Institute for Dental Specialists, as well as my practice, Benko. Gilead Dental Marketing, which is in Southern California. Ace Chat, great chat service, which can be embedded into any website. Geislich Materials, you all use Geislich products, I'm sure. Stella Life, a fantastic natural product for post-operative healing. And BioHorizons, we've been using for dental implants for the past about 15 years. Today we have the great fortune of having Dr. Peter Nordland here. Peter comes with, he doesn't need an introduction. We all know how Peter has perfected the art of periodontal plastic surgery. He taught his own courses for many, many years in Southern California, and it's been very exciting to have Peter show us the way in restoring soft tissue. Peter thought that this is a problem we all have. You know, what do we do in the area of the dental papilla? That's what everybody sees. And Peter has some techniques and also some philosophies, which I think we can all benefit from. So Peter, thanks for being a part of this webinar.
Thank you, Lee. Are we ready to start?
We are ready to start. Go.
Okay. Well, thank you, Lee, for the invitation to be in your webinar series. We talked that one of the things that's near and dear to my heart is periodontal plastic surgery. And in the heart of that, I think, is the restoration of the lost interdental papilla. And this is a branch off of a lot of our other plastic procedures like root coverage and soft tissue grafting. So can you see my screen okay, Lee? I'm going to assume that you are and start in.
Yeah, so, I can see just fine, Peter. Thank you.
Super. Thank you. So yeah, some of my background, I practice in La Jolla, California. I love the American Academy of Aesthetic Dentistry and promote it as much as I possibly can. And those of you that are out there listening, if you get an opportunity to attend, please go. I think you won't be unhappy. I've been a teacher at Loma Linda University for over 25 years. And also have run the oroplastic microsurgery course at Newport Coast Orofacial Institute. That's been a fun program. I've been the president of the Internet and currently the president of the International Society of Periodontal Plastic Surgeons. And that's an organization where we focus on a lot of the things I'm going to be talking about and a lot of things I'm not going to touch on today, but our plastic procedures. The International Journal Periodontics and Restorative Dentistry, I'm on the editorial review board there. Also with the Journal of Cosmetic Dentistry on their review board. And one thing I'm very proud of, Ronnie Goldstein's newest textbook, Aesthetics in Dentistry, that I co-authored the chapter with Dr. Laura Souza on periodontal plastic surgery. And I think it turned out really nice. Here's what the book looks like. And it is kind of pricey. It's two volumes, but it's an incredibly complete book. P.D. Miller, Pat Allen, and myself, about, more than 30 years ago, we established a study group, started off, and we had a mission. And now it's turned into the International Society of Periodontal Plastic Surgeons. Our mission really was to, we knew root coverage was pretty much a done deal. What about the interdental papilla? That's been the elusive butterfly for a lot of us. So I want to mention a couple of disclaimers. One, that I'm going to promote some materials and instruments, but I don't receive any money, funding, or anything from any of the instruments that I've developed or any of the materials I'm going to show. If I promote a product, it's because I believe it will benefit the eventual outcome of the techniques. And so if I believe in a product, I don't mind giving credit for that. And then also, I have not altered any of the images that you're going to see. A lot of you periodontists know that last April, we lost the pioneer in microsurgery. That was Dr. Dennis Shanilak. He developed the Microsurgical Training Institute in Santa Barbara. I mentioned that I had run a microsurgical training course also. And how did Dr. Shanilak and I both get started in that tangent from periodontal plastic surgery? And that's mostly through Dr. Gary Carr, an endodontist here in San Diego, who has been the one person that has been really the introduction of microscope to endodontics and periodontics. Now we see that most all of us use some form of magnification in what we do every day. If it's loops, I have 4 microscopes in the office. That's a little overkill, I'm sure, but we have 4 scopes in the office. This is, in this picture, you can see P.D. Miller, Mike Picos attending one of the programs. Well, who's using magnification in the US? Well, we know that endodontists lead the field, and virtually almost every endodontist uses a microscope. Very few of us periodontists use a microscope, and you can see the pitiful numbers for the rest of us out there. As I mentioned, we started an international society, and fortunately, just last September, that compendium ran an article that focused on our organization. And it's international. You can see Dr. Ono, and you can see a lot of other well-known periodontists that contributed to it. One of the papers they published about my technique was on what we're talking about today. So with the heading of periodontal plastic surgery, I like this quote by Oliver Wendell Holmes, because he said, and I love it, that man's mind stretched by a new idea never regains its original dimensions. I should say women's too, because I'm sure we have a lot of women that are part of the viewing audience today. But I think that's really important. I want to try to stretch your minds. Under the heading of periodontal plastic surgery, today I'm talking about papilla reconstruction. And I'll talk about some of these cases that you're seeing here. I'll go through how we fixed them, how we ended up, and steps taken to get there. So many of us see these kind of disfiguring problems patients present with virtually every week, every day. I'm blessed to know some really great people. This is Dr. Dennis Tarnow, and through the American Academy of Aesthetic Dentistry, here's my family and Dennis's wife, Karen, and his son, Derek. And the neat thing about this meeting is you get to know people on a very special level. And so one of the times Dennis and I got together, we developed the classification system for papillary loss and published it. And we used 3 recognizable landmarks. We use the contact point, interproximal CEJ, and the facial CEJ. And so, for example, a class 1 for papilla loss has the tip of the interdental papilla between the CEJ, interdental contact point, and the interproximal CEJ. And we'll go into this a little bit more detail later on. Another paper that Dr. Harinder Sandhu, the head of the, let's see, his school is University of Western Ontario. He's the dean of the school. Anyway, we did a paper together, and in this paper, we talked about some important things like the review of papilla classification, anatomic considerations, patient biotype considerations, value of microsurgical approach, determination of graft volume, which is important, donor site based on volume that we need to harvest. There are many misinterpretations of the Tarnow's, call it quote unquote 5mm rule. Should we consider inlay or onlay grafts? Avoiding releasing incisions through the delicate papilla and preservation of blood supply with minimal tension and wound closure. And a combination of a tunnel and a coronally positioned flap is basically what we're going to be talking about today. Microsurgical instrumentation, I think it's really important that we're using small instruments to get into this tiny area. No releasing incisions and protecting the blood supply. I'll show you my special suspensory sutures that will really help stop relapse of tissue back to its original position. So as I mentioned in the compendium, I published this article. Another article that I published in the International Journal, Periodontics and Restorative Dentistry, was on a technique, my technique to be able to gain tissue into this tiny little area. And this reprint is available if you'd like. So let's get into it. I don't always need to do a grafting procedure. Sometimes this patient, Cynthia, reports to me, as you see here, she had a history of a deep localized periodontal pocket, which had a bone graft placed, attempted, 7mm pocket remains, and an aesthetic defect. So she has long roots, and that's going to allow us to do something else, and that is to extrude the teeth. So we started the extrusion process. I asked her to see, she comes down from Northern California, so we're having a little bit of a long distance orthodontic treatment, but this is after 3 months of extruding 8 and 9. As these are being extruded, I'm using the microscope and I can see right there in the interproximal that there is a defect on tooth number 8. And the mesial defect was one of a sort of a lateral root fracture that when the periodontist that saw her tried to do a bone graft, the reason he failed or the procedure failed was because there was an inherent underlying bad problem, and that was that there was a root fracture. So I'm pulling the tooth down with the help of the orthodontist. And as we're getting closer and closer to a final point, you can see here's where she started. Look at the apices of 8 and 9 compared to her lateral incisors. And now look at here we are, we've pulled them down about 3-4 millimeters. And now I can do sculpting to be able to reposition the tissue. And a lot of our orthodontists that are here today, I wonder if you remember Vince Kokich talking about Atherton's patch, because as the sulcus is everted, that red tissue, which will mature later on, is called Atherton's patch. And so what we're doing with the extrusion, you can see the tissue everting and having access. So now we can do restorative dentistry more routinely than we could have ever done, and also pockets are gone. What about anatomic problems? We can see the shape of this root right here is more of a teardrop shape. I hope my cursor's coming through. So the teardrop shaped lateral incisor presents some special problems. And that oftentimes, a buddy of mine, Dave Matthews from Washington, he will look at the adjacent papilla. And in this case, we look at the adjacent papilla. The interproximal papilla is not really deficient. What is deficient is some tooth structure there. So we have to look at the right problem or the right solution to the right problem. So here we have an anatomical issue. You can see the adjacent papilla heights. If I draw a line, you can see that that's actually within normal limits. A connective tissue graft is a biological alternative to Miller class 1 and 2 recession defects. Laura Souza and Ed Swift helped me on this paper. And what we're doing is we're looking at options here, class 5 restorations. We would like to put a final nail in the heart of class 5 restorations, because do they really help us? Almost pretty much nil. So Randall comes in, he's got composite restorations, you're undermined with bacteria, tissue's inflamed as a result. So I'm going to remove those and graft those. Again, this is more of garden variety connective tissue grafting, but using these same concepts of our ability to add tissue, I'm going to expand that as we get into the papillary area. So this is a program that I shared with the International Journal of Periodontics and Restorative Dentistry, their annual meeting. And one of the important aspects when we're looking at predictability, we look at blood supply. And a Newbold study that was done at Loma Linda University, if we looked at a free gingival graft, about 30% of the cells of that graft were contacting a vascular bed. When we thickened the tissue and went with a thicker free gingival graft, we could get up to about 42%. When we look at connective tissue, we're well up around 80%. And when we use a tunneling procedure, we can basically surround all the cells with blood supply, creating nearly 100% of the cells contacting a vascular bed. So I mention this because Jay Siebert, some of you might remember Jay from the University of Pennsylvania. This is a case that he demonstrated. And Jay was a master using an onlay type of graft. The problem with an onlay graft is we get the blood supply from the sides. Here's Jay's final outcome. Let's look at what he did. So Jay used a large chunk of palatal tissue from the tuberosity to graft. And you can see from the sides of this that it's a pretty thick graft. Here it is as it's starting to heal. And here's the final healing of that, but he's then going to go in and he's going to do some dermabrasion to smooth that down. And his final result is pretty darn nice. And if we look at where the tissue levels are, it's actually still a little deficient if we use Dave Matthews' way of looking at the adjacent tissues. So if we're going to talk about papilla reconstruction, blood supply is key. And my perspective is we have to use a tunnel, we have to use an inlay graft, and onlay graft is really going to be limited with blood supply. There's other materials out on the market. We know of fillers like Restylane, collagen fillers, alloderm, connective tissue. Of those things, the patient's own is number one. What about Restylane? Well, some of you know Bill Becker, John Kois, and Burton Becker. These guys were involved with a study looking at the use of some of these injectable materials. And what they showed is that there was some potential benefit, however, not in keratinized tissue. And I talked to the investigators in this, and they had one clinical case that indicated positive change. Restylane is not available to dentists. The manufacturer Medicis sells it for treatment of the nasolabial fold only and claims it will last for 6 to 12 months. And of the investigators, 2/3 of them that I contacted said they saw little, if any, positive clinical change. Well, what do we know about the papilla? We have some anatomical considerations. For example, as I've indicated here, the papilla is such a small area to be augmented. So then we might want to consider using magnification. Cell survival is greater for inlay grafts than onlay grafts. Putting tissue cells inside versus on top of creates better blood supply. We know that the injectable materials are short-lived. Allograft reportedly resorbs over time. That's what Randy Harris reported in 1994. Well, so what were some of the milestones that helped me change my mind in terms of ability to make predictable grafting of papillas? And that is, the first milestone was, of course, using connective tissue. So a patient that comes in has 7 millimeters of recession, we can very predictably add keratinized tissue with good aesthetics. We can't see any sign of any incisions, and this is because I'm using a microsurgical approach. Modern gingival augmentation techniques can offer predictability in root coverage, regeneration of attachment, and cosmetics. So these kind of cases, I would say, when we have nice, rich, full papilla adjacent to these areas, are generally very predictable. Pat Allen and myself, we did a paper for the Journal of Cosmetic Dentistry back in 2012. And one of the things we came with our consensus when we look at myths versus realities with root coverage grafting, that connective tissue grafts remain the gold standard in root coverage grafting. And you all know that Pat has been a huge proponent of other options. Second milestone is tunneling. When we have releasing incisions through the papilla, we can create scarring. I want to encourage you all to never really make incisions through the papilla. That's the kiss of death. A patient on the left came from Florida, actually, Lee, to come see me to help him. The patient in the center here is from San Diego, who had periodontal grafting done. And here's a gentleman that comes from Northern California and the problems that he's had. And basically, you can see this scarring in the incision line from a previous surgery. I'll show you the cases treated here shortly. It says AL in the use of subperiosteal envelope soft tissue grafting for root coverage. International Journal Periodontics and Restorative Dentistry, 1994. Andrew Allen, he goes by Sandy Allen. And Sandy, I would have to give a lot of credit for the concept of using a tunnel. So what about patient care? This patient comes to me from Dr. Sherilyn Sheets, and she's got a defect here she's got root exposure here. There's actually class 5 restoration. There's a deficiency here and exposure there. So what we're going to do is we're going to treat the root coverage, or we're going to try to level out the papillas. And here we are, a little bit more of a close-up. And you can see the deficiency of the papilla between numbers 10 and 11. Oops. You see the x-ray of the case. Going to remove the composite that was placed on tooth number 10 and tooth number 11. Going to harvest the graft from the palate that's the shape of the tissue that we want. Also, if we have a pocket associated with upper molar tooth, I'm going to strategically take our graft so that it will help to reduce the pocketing there. If I'm not wanting to reduce pocketing, we could be creating recession in that area. So just a word of caution in terms of your palatal donor site. I've harvested a shape that will be utilized for the final. And here I'm laying it over the surgical site just to get a sense if we have enough tissue, how it's going to work into the scheme. And I'm going to put that into a tunnel. So this, I've now sutured the tissue, but there's nothing exposed. Everything has been done into the tunnel, and so there's no soft tissue exposed at all. And I'll talk about suturing technique in a little bit. I always will make a palatal stent. Whenever we're harvesting palatal connective tissue, I want the patient to be protected with a nice palatal stent. Here we are as we've gone on to heal. And now you can see if we draw that same line where we end up for Sherilyn's patient with root coverage on number 10, papilla augmentation between 10 and 11. Another milestone, using a suspensory suture. So here I was a while back, and I'm doing a case where I wanted to augment the papilla right here. And what I found is that as I'm doing the case, and I think I'm almost done, that the tissue wants to go back to where it was. The memory of the tissue wants to pull things back to where it was before. So this is back in 1996. Well, right around that time, I had done a case where I was doing ridge augmentation for 2 teeth, 8 and 9. And what I found was that when I put the bridge back in, that I wasn't getting it to look like the teeth were growing out of the tissue. So what I ended up doing was taking a suture and actually running it over the contact of the bridge in a way to anchor or suspend the tissue in place. And so what I found is that using what I call a suspensory suture can actually be very helpful when we're trying to augment the interdental papilla. So that's another milestone that has helped me to position tissue in the final way. So the suspensory suture here you see in this particular case, I've used that suture to really suspend our tissue where we want it to be. And as we go on to heal, you can see we actually got pretty good fill in that interdental space. Well, what else? Well, here's a case where I've got really, I'm asked to do root coverage, and I, as P.D. Miller would say, and P.D.'s probably listening in right now, but as P.D. Miller would say, that this area, we have nice, fat, juicy papilla. That gives us really good blood supply. So what I'm going to do is then say, you know what, if I have working access, if I can get at that space between the teeth, if I can get my tissue into that space, then we have the possibility of being able to augment that area too, not just root coverage, but also at gaining tissue in that tiny little area. So being able to have access to me was a big milestone. And creating access, well, we can't make our incisions bigger, but we can make our instruments smaller. So here I am doing one of the hands-on courses, and we're doing papilla augmentation with attendees watching the whole process. So I like to use our periodontal microsurgery as a real big benefit. And so I'll be using a microscope in what we do. I've developed my own instrumentation with Hugh Freedy. With the microscope, like I said, I've got 4 in the office. This one happens to be a Zeiss. We use global is another workhorse. And then the other thing I had to do is really create smaller instruments. So now you can see this is the N6900. They put my name on it, which I love because I don't get a penny for the sales of the darn thing. But you can see compared to a 15C, and we know the 15C is smaller than a 15, that we can shrink our instruments down to be able to have a much smaller incision site. The other nice thing about my particular scalpel, and I would encourage you to give it a try, is that it's bendable. So here you can see the 15C as we compare it to the N6900. And like I mentioned, it's bendable. So you can see here, I've taken one of my scalpels and I've given it virtually a 90-degree turn. And that can come in handy when we're trying to undermine the interdental papilla. It's also pretty tiny. It's less than 1 millimeter wide, and the shank can bend too. And the shank bendability is helpful because many times if we're using a straight line shot at things, we're going to have to angulating our shank through the patient's nose, which is not going to work. So having the ability to bend the shank is a big help too. Another milestone, challenging established dogma. So we've had concerns about papillary anatomy, as I mentioned, the 5 millimeter rule, and papillary volume. So just want to cover some of those things too and challenge the dogma that's been out there with that. With our papillary anatomy, we were all taught in school that there was an interdental caul. Well, does the caul really show in the anterior? Generally not. Here you can see a cross-sectional view of after I've extracted a central incisor. There is no caul there. It's a pyramidal shape. What is the theorem for formula for volume of a pyramid? Well, the volume is 1/3 length, height times width. So if we are missing 2 millimeters of papillary height, if we have 2 millimeters by 2 by 2 over 3, the amount of millimeters, cubic millimeters that we need to graft that space with 2 millimeters loss is 2.3 millimeters. Now look what happens though when we get to 4 millimeters. It jumps from there to 21 plus millimeters. And if it gets bigger, we get to 72 when we have 6 millimeter height loss. And go farther, 8 millimeters, 170 cubic millimeters of tissue loss, and 9 millimeters, that's 243 cubed. So it grows exponentially when we have height loss. And so to make a point, usually we're underestimating how much tissue we need when we're trying to restore these type of things. So again, looking at the anatomy, we're looking at a pyramid. We're not looking at a caul and developing that. How about the effect of the distance from the contact point to crest of bone on the presence or absence of interproximal dental papilla? This is the 5 millimeter rule paper that's quoted so much by Dennis Tarnow. And in this paper, they had almost 230 sites, 30 patients. If the space was visible apical to the contact point, the papilla was deemed missing. If the tissue was filled with the embrasure space, the papilla was considered present. The results showed that when the measurement from the contact point to the crest of bone was 5 millimeters or less, the papilla was present almost 100% of the time. That's what's quoted all the time. Unfortunately, when the distance was 6 millimeters, the papilla was present 56% of the time. And when the distance was 7 millimeters or more, the papilla was present 27. That's what you always hear in terms of the quoting. And here's from Dennis's paper at the 5 millimeter point. When we look at this 5 millimeters, okay, well, 100%, 100%, 90%. So most of the time, if we have that distance, the papilla is present. But if we also look at this paper and go out to the 9 millimeter level, even farther, that 25% of the time, the papilla was present. So what do I mean by this? Where am I going with this? My point is that even if you have a 9 millimeter distance, the papilla can still be present. Would we prefer to have the bone closer? Absolutely. But is it essential? Absolutely not. So my point is that we don't need to have a foundation of bone. Now, we've all seen a flabby ridge under a denture. That's unsupported tissue. We've all seen patients that come in, they've got an 8, 9 millimeter pocket interproximally. That's unsupported tissue. So can that papilla be present with unsupported tissue? Bone is missing? Absolutely. So when Millie came to see me back in 1996, here's the way she presented. And Millie had this little white aspect of alloderm sticking through the tissue. And according to Millie, she had had 3 augmentation attempts, and this is where she ended up. She saw a periodontist, and this is as much as they could gain. According to the patient, like I said, she found things got worse and worse each time. And when you look at Millie, you can see that she's had wear on the incisal edge here. This tooth is different shape than this tooth. She's had build out on the mesial side of number 7. So there's been a lot of attempts at changing the tooth shape, and this tooth really has been extruded when we look at the shape of it compared to the neighboring tooth. So here she is pre-op. Here we are when we're done. How do we get there? I'm going to take a pretty large piece of connective tissue. Now realize that this connective tissue that I'm going to place, I have no releasing incisions. I'm making our sulcular incision and getting that tissue into that space underneath this area, which can be very difficult and challenging at times. But here we are after I've been able to do that and healing. Now, here's before we've gone to final restoration. That composite is still there, and I'm going to ask her dentist to restore this tooth and to build it up so that we're going to have a result that looks like this. So just zooming in on that space, here we were from beginning to end. And right now it's been 23 years post-op, and Millie has been really good about coming into my office for regular periodontal maintenance. And I hope that my hygienists are noticing that, because they're the ones that have been maintaining her. And here she is, more of a close-up. So 1996, 2006, and last year. Now you notice here, the restorations have been built out. Now you might say, well, look at those ledges, but I'll tell you, Millie's maintaining and has done a marvelous job. Her dentist, Dr. David Hornbook, did a great job too in creating a nice seal on those. Many times I'll do root coverage procedures simultaneously with our papilla augmentation. And so here, that's what we're doing in this case, is I'm extending a graft to cover and also extending it proximally. This patient seems to have a small need. However, here's what Janine appears with. She's unhappy with her black triangle. She had orthodontic root alignment, but it was not really that successful because she's got partial ankylosis of tooth number 8. You can see number 8 is a little bit darker than number 9. She's had pre-existing endo on number 8, and she has detailed but realistic expectations of what she would like to achieve. Here's her x-ray where we started, and here she is pre-op, and here we are post-op. The other nice thing about our classification system is that we can create sub-classifications too. So for example here, if this is a class 1 interdental papilla, we can make it a class 1 if this is 2 millimeters, class 1-2, or -3, or -4. So we can make sub-classifications as well with our dentistry classification system. So what are our suggestions that we have with all of this? Well, I'm going to recommend that we use a microsurgical approach. I think that the instrumentation is important, using a microsurgical approach to things. Using the microscope really helps because you can see things you wouldn't otherwise see. Maintaining the papilla isthmus. And I've created a video, and I'll kind of go into this in a little bit more detail. But if we start making incisions that really damage the isthmus of the papilla, we're kind of dead in the water. I want to recommend that we go with the tunneling approach, because that's the best way to maintain great blood supply. We need to have adequate donor tissue, and sometimes you have to hunt around to find that adequate donor tissue. We want to have a surrounding blood supply because we want to have an inlay graft, not an onlay graft. The suspensory suture really is helpful to help us position the tissue where we want it to be. And then I'll show you our positioning sutures that help to anchor the tissue in place and create prolonged tissue stabilization. So this patient has had multiple surgeries and comes to see me with what she calls her disfigured papilla. And so I'm going to again harvest the shape of tissue that's going to be fitting for what our need is. I'm overlaying it in the graft site, and we're using sutures to position the tissue, sutures to help bring the tissue down around the central incisor. So I label this a positioning suture. And circumferential sutures to help bring our tissue down as we want. And then our suspensory suture. And the suspensory suture, as I mentioned, was one of my milestones. So here we've changed this class 2 class 2 papilla to class 1 papilla. I find that lower anterior teeth are extremely tough, that when we look at the interproximal space, we have very little room to work. And many times our instruments have a challenge just getting into those spaces. So I will really discourage orthodontists to extract a lower anterior tooth because it becomes so difficult to correct that problem. So I developed an animation, and Lee, let's hope that our sound comes through with this. If it doesn't, I'll talk over it. But I developed this to be able to make sense of how I'm getting the tissue in place. And I can hear it on my end. Can you hear it?
Got it, Peter.
Can you hear it? Basically think of our restoration as like blowing up a bicycle tire. We're taking the existing tissue and exploding it, blowing it up.
The restoration of the lost interdental papilla. In nature, we notice when something is missing. Now, using microsurgical techniques, we have the ability to restore lost papilla. To close the interproximal space, we are generally concerned with 3 possible approaches. The first method is orthodontic root approximation to close or pinch down the tissue space. Proper root alignment causes space closure and a pinching down of the interdental tissue. Incisal edge wear will become more obvious, necessitating restoration. Another method involves restoratively changing the tooth shape. A third approach is a surgical addition, which is what we will demonstrate in the animation. Here is a cosmetic defect in the maxillary anterior. Here is a healed result using my new microsurgical technique. This technique will be described and detailed in our animation. The animation should allow for easy understanding of the nuances of the surgical technique. First, the doctor should classify the defect. Using the Nordland classification system, we can determine just how much change can be accomplished with any papilla regeneration technique. The classification system, as published in the Journal of Periodontology, details different levels of papilla loss. A normal interdental papilla fills the embrasure space to the apical extent of the interdental contact point. A Class 1 papilla, the tip of the interdental papilla, lies between the interdental contact point and the most coronal extent of the interproximal CEJ. A Class 2 papilla has the tip of the interdental papilla lying at or apical to the interproximal CEJ, but coronal to the apical extent of the facial CEJ. A Class 3 papilla, the tip of the interdental papilla lies level with or apical to the facial CEJ. Here you can see the typical 7/8 scalpel handle with the 15 blade. Using a straight scalpel necessitates releasing incisions and larger incisions. You can get a sense of the large size of the classic 15 scalpel when we compare it to the new microscalpel blades. This particular blade is the Nordland 6900 blade. The mounting of the scalpel blades is quite different from that of traditional blades. The newer scalpel blades mount on a rounded handle. Because nothing in the body is straight, the N6900 blade can be modified using orthodontic bending pliers to be able to create new shapes and contours. Here you can see the modification of the N6900 blade using the orthodontic bending pliers, creating some of the typical contours we might expect to use with our surgical procedures. Previous flat blade handles did not allow for the use of small muscle rotation and encouraged the use of larger muscles with more inaccuracies and movement. Round handles use small muscle rotations and create more precise scalpel movement. First, measure the desired gingivo-incisal height. In that way, you can tell the amount of total needed tissue for the final result and how much volume of tissue will be needed to be harvested from the donor site. Usually, I will start with the scalpel unmodified. A sulcular incision should be extended circumferentially around the adjacent teeth to the crest of bone. Later, the scalpel will be modified to form a J-hook contour. A split thickness dissection is used on the facial with a second customized angled blade. Papilla mobility is achieved through a split thickness dissection under the facial tissue extending up through the attached keratinized gingiva past the mucogingival junction. The doctor must evaluate the amount of tissue needed and choose a donor site with adequate tissue dimensions. The desired gingivo-incisal height to be augmented must be measured ahead of time. Once adequate donor tissue is harvested, a lasso suture is used to pull the tissue into position under the undermined papilla space. A composite restorative material has been placed at the contact point to support the suspensory suture. A suspensory suture is essential to position the graft and keep the recipient tissue from retracting due to the pressure of the lips and musculature, such as the orbicularis oris muscle. I recommend avoiding metal and plastic interdental cleaning devices.
I'm going to stop and go on and give a few more examples. So Donna came to see me. She had had periodontal surgery in Los Angeles and was unhappy with the papilla loss between numbers 9 and 10. And she saw an excellent periodontist, and he got rid of the pocketing, which is great, but the outcome she didn't like. So although the pocket reduction surgery is successful, she's unhappy with the outcome. Now, she comes in and she had this little plastic artificial papilla that she had seen a lab technician to make because she was kind of wanting to give me a sense of what she was trying to recreate. I said, that's not realistic. That's totally fake. And if we had tissue down like that, it would look awkward, to say the least. So I'm measuring how much tissue are we going to need. And I'm going to want to create some root coverage here, create root coverage here, and also, of course, augment that area. So I'm coming up to the palate, harvesting the piece of tissue that we're going to need. So I've measured what we needed and going to create then our donor tissue. And now I'm going to want to get that piece of tissue into the area through the sulcus. And that can be tricky at times. So you can see I've positioned the tissue under this area with sutures on both ends. I've got sutures that are running to keep the tissue circumferentially around the tooth. And I've actually put 2 suspensory sutures through this tissue to help keep it where we need it to be. You can tell I'm using Gore-Tex sutures here. This is a 5/0 suture and that's a 6/0 suture. And I've actually used a gut suture here because I wanted to pull the tissue. And I'll try to show you what I mean by that. So here's our final outcome, where we started and where we ended. Now, Tom came to see me, and Tom had had some procedures done and was very unhappy with the outcome of the gingival grafting procedures, connective tissue grafting procedures that were done. Here you can see the way he appeared and was mostly concerned about the space here and the space here and the space here. After I did a procedure for him, I really felt like this root proximity was a real issue because it was so small that I couldn't even get my suture through that. So I tried my best, used a releasing, back up. I made a window, sort of like a vista window or a pinhole window. It's a lot bigger than a pinhole, but making an incision to be able to bring our graft tissue down through this area into this area here. And you see I've taken a pretty long piece of tissue, trying it into place, and then here we are suturing it into place, but having challenges between that tight root proximity. As it went on to heal, I still felt we were super deficient right here. And so I had to call upon orthodontic help to be able to make this, be able to create some space to work. So orthodontic root separation by Dr. Megan Cornell from Valencia, California, asked for her help. And here you see she's been able to separate those roots. So now we have some working room. I'm going to use my microscalpels to be able to get underneath that tissue, bending this microscalpel. And then here we are in April of 2017, moving on a little later in healing. Now, April of 2018. And if we look at where we started versus where we ended up, I was surprised actually that we could make Tom happy because he had so many requests for me to accomplish. And he actually, at this point, Leslie, you probably remember him tearing up in the office because he was so ecstatic over the outcome. So I want to thank Dr. Licorna for her help orthodontically. And now she's actually closed the space down, as you can tell, and helped to really create a papilla that's normal and natural. Lori had a procedure done. It was actually root planing, where root planing was done and a cut was made through the interdental papilla. And so the restorative dentist office where they had that problem contacted me and said, can you do anything about this? And I said, well, I'll sure try. So again, we're going in microsurgically using our scalpel that we can bend, giving contrast to get underneath the papilla. I'm measuring the thickness of the tissue we're harvesting, putting that in a trial way. Now, when I'm getting that tissue into position, it's important. This is a palatal view here. And you can see my suture needle coming through at the base of the papilla on the palatal side. I mention that because we want to be sure that we're not running through a really narrow area and putting pressure on a tiny little amount of tissue that would essentially tear that. So making sure that the sutures run through a solid bite in the tissue is really important. So here you can see I've used a gut suture that I'm not going to have to remove. And I've got a 6-0 suture here and a 5-0 suture there. And we've run some composite between the teeth to be able to hold our tissue in place. And then here is Lori with her healing. And you can see that we've been able to inflate, basically, almost like pumping up that inner tube, inflate the papilla. So where we started and where we finished. Now I must say, this is a new restoration, a new crown. So to be totally clear here, we augmented, and she has a new crown in this spot. Here's the papilla donor tissue harvesting. I've used some liquid suture to cover over. I've replaced the epithelium. I will try to always do that, where you take the epithelium away, and then rather than discard it, I'm using it as a bandage over the tissue donor site. And here you can see as it's healed. And basically, you can't tell anything has been done. And using that palatal stent, patients really have virtually no discomfort. And I say no pain, no discomfort. And we can do the same thing around implants. So here I'm challenged because, first of all, this is a tissue level implant that should have been a bone level implant in 3 different spots. And Neva, the recipient of these implants, is very unhappy with her smile. So she's come to see me to see if we can get interdental help as well as root coverage. She's unhappy with the outcome. I'm going to do the same type of thing. And now, as she's gone on to heal, she's actually pleased with her smile. So yes, we can augment, cover roots, cover implants simultaneously. Excuse me. Mary had periodontal surgery, and she had pocket elimination surgery done. And although the pocket elimination was successful, the aesthetics were not. And she was really devastated with the final outcome. So her dentist sent her to me, and she actually was mad at her GP for sending her to what she called her butcher that created this unesthetic result. And I told Mary from the beginning, she's got small square crowns. They're going to need to be lengthened. She's got spacing, obviously. We want to add tissue and create a better orthodontic positioning for the teeth. So here's Mary in her own words. Hopefully, Lee, our volume is appropriate.
My problem was that I had had some previous surgery on my gum, and on the tissue had been sewn up higher than my gum line, so the roots were exposed. And I went to 2 other periodontists, and they said, you probably will have to live with this because we can't help you out. You could see the root above the gum line or above my tooth line, and therefore I didn't want to open my mouth. I couldn't smile, and it wasn't acceptable, and I had to find somebody that could do something for me. And then I found Dr. Nordland. When he told me that he could do it, I had complete confidence in him, because he said, I have done this before and I can do it and do it successfully. With my grafts, you can't tell. You would not know that there had been a graft. In fact, when he did it, I went back a month later and he thought it was too high, and so he shaved it down. It's perfect. It's the same as the other side of my mouth. It's a wonderful thing. Prior to this, I didn't open my mouth. I would look down. And now I can smile and enjoy having people see my teeth. I asked Dr. Nordland if I was going to be the same as I was before I had the surgery, and he said, yes, you will be the same, and I am.
Thank you. So here was Mary back in 1997, and now 2010. So we started out with this defect, and because I have room to work, I'm going to augment the papilla as a first step. We're also going to consider orthodontic root approximation, and she's receiving some restorations, again, by Dr. David Hornbrook. So grafting for the papilla augmentation root coverage number 7 and 8, orthodontics to closing embrasure space. So that's the second step. So we can see here, you can see I've augmented the tissue. And now Dr. Bud Rubin, orthodontist, has brought the roots closer together. Now we're going to do aesthetic crown lengthening. And as she said, I wanted to smooth the tissue down. So because I didn't like the aesthetics, I wanted to create longer teeth. And here we are after doing the sculpting. Sculpting is my term for aesthetic crown lengthening. And here we are now, and she's now ready to receive her restorations. And I think David Hornbrook did an excellent job. And she loved her restoration so much that then she had him restore the lower anterior as well. Now she's actually lost number 7, and I've placed an implant for her, and we've been able to maintain in that same area pretty decent papillary aesthetics. Next patient comes in and has multiple surgeries, disfigured papilla, again doing the same type of thing, harvesting tissue, using the sutures as we described earlier, to be able to change a class 2 to a class 1. Fernanda comes to see me, and she obviously is not smiling, and this is why. She's got this space. So she had seen an excellent restorative dental office, Dr. Doherty's office, and so here's the problem that she presents with. And Paul asked me, can you do anything about this? I said, well, we'll give it our best shot. So here's where Fernanda starts. You can see she's got a small restoration there on the distal. Here's her x-ray. She had some incipient bone loss going on there. And here we are after grafting the area and her 9-year post-op. Our next patient comes and he says, we have nicknamed him Mr. Ghastly, because what Robert said was that his tooth appeared ghastly. Now he's from Ireland, and so that matches perfectly with his personality. But here's the way Robert appears. So we're going to do augmentation of his ghastly tooth. You can see the tissue that I'm harvesting. I'm removing the epithelium. I'm going to replace that in the palatal wound where it came. Trying this in for size. Suturing the tissue interproximally. You can see that I've added composite interproximally, so the suspensory suture is going around that area. And here we are with our healing. Robert told me that he went to his restorative dental office in North County, San Diego, and his dentist would always take out the picture of the before and after. Dang, he said, how did he do that? So you're getting some insight into some of the tricks of the trade. Now, yes, is it smooth? No. Is it irregular? Absolutely. Can we smooth that down? Yes. And here you can see, without doing anything, as it's gone on a little bit more time to be able to smooth out on its own. Now, yes, if we look at the papilla height, it's not the same. We still have a deficiency there, but we're filling the embrasure space. So again, where we started and where we ended. So Lori, I showed her case earlier. We changed Lori from a class 2 to from a class, let's say between a class 2 and 3, and got her to normal. You can see our horizontal line that I'm using as a gauge versus where we end up. Class 1 interdental papilla, Janine Cooksey. Janine, way she appears initially, and her final outcome. So class 1 interdental papilla. So remember our landmarks that we talked about. Class 2 with Millie, and the way she initially appeared. As I mentioned, she had 3 previous attempts at augmentation of the papilla. and her final outcome. And Mary, you saw her video. So I've gone through a number of cases, before and after, before and after. Just a few of the ones we covered already today. Using multiple disciplines with ortho and restorative help, as I've already described. So some of the suggestions, again, I want to recommend we have a microsurgical approach, use our small microsurgical instruments. The microscope really helps. Maintain the papilla isthmus. If we cut through that, I would consider aborting the procedure. Highly recommend a tunneling approach. I don't think we can achieve the same thing if we slice through the blood supply in this delicate area. We need to get an adequate amount of donor tissue. Can't stress that enough. Sometimes you're looking at the tuberosity. Surrounding blood supply, so important to provide nutrition for the cells we're grafting. Dispensary suture to keep our graft in place, and positioning sutures to do the same. And then prolonged tissue stabilization with our suspensory suture to help keep things in place. So my goal today was to try to stretch your minds, and I hope I've done that, at least in a small way. So I want to thank you, and I want to thank Lee for the opportunity to be here. I'm happy to, and I should have said this in the beginning, I'm happy to entertain questions. Now I should have taken them through the presentation, but fire away.
There is a Q&A box at the bottom, so if you have a question, just push the Q&A box, type in the question, and I'll repeat that question to Dr. Nordland. So Peter, let me start off a little bit. Let's talk about incision design a little bit more. So we talk about the tunneling procedure, and except for that one horizontal incision, the large pinhole as you described it, you were able to thread all of that tissue through the sulcus, right?
Yeah, I found that having an extra opening to insert the tissue can be helpful, especially in bigger cases. But I try to avoid that if we can. It does make it a little more challenging, but I think it works out better.
So I was lazy when I was doing a vertical mucogingival incision in order to be able to improve my ability to tunnel and do it faster. And I learned that technique somewhere in California.
Yeah.
Is there a downside? Because the access was so much easier for me when I would make that mucogingival incision, not going through the papilla. Of course, you'd spare the papilla. So is there a downside risk of elevating the tissue that way and then doing a couple of 6-0 vicral sutures to suture up that vertical incision?
Well, the Vista technique, Oma Zadeh popularized that from USC. And he makes a vertical incision up in the vestibule. And then John Chow, as we all know, with his pinhole technique, has popularized things too. But if we can do things without making those extra incisions, I think that ultimately the patient's going to benefit with a little bit less trauma. Now, we always have to weigh the risks and the benefits of having less working room. Now, you had seen in some of the earlier cases that I showed, I had some gut sutures in place too, because I didn't want to have a suture that I had to go in and remove. So if I'm placing a suture to hold the tissue in position, and the one thing that gets challenging is you get that tissue underneath your flap, you can't see where it is. And so you need to be able to stabilize it, especially under the interdental papilla. Otherwise, you have no clue where that tissue could migrate to. So getting that tissue anchored underneath the interdental papilla, to me, is key. It can help to have more access, no question, but I'm going to try to avoid extra incisions if I can.
Okay, and that makes sense. And yeah, there were a number of times when I would and a number of times when I wouldn't. When you're doing your initial recipient bed design, let's talk about the papillary area itself. And I understand we're doing a split thickness incision through the papilla. How far palatal are you taking that incision?
Okay, I'll make a sulcular incision all the way around the adjacent teeth. I want to basically undermine the interdental papilla, and the amount of dissection you have to do will vary. You have to gain mobility of the interdental papilla, as I showed in the video, and be able to have the ability to move that tissue around. So how far palatally do I go? I'll just say I go as far as I need to create that kind of mobility. The bigger key is the facial dissection, getting past the mucogingival junction to be able to have mobility and pull that tissue down. That's a bigger key, I would say. So usually I'm going circumferentially around the adjacent teeth and undermining the interdental papilla totally, but most of all, extending the facial incision so that we get mobility of the gingival tissue.
Okay, and that of course allows you to coronally reposition everything, and
Right.
it has to be mobile. Let's talk about recipient, or let's talk about donor tissue. You talk about going to the tuberosity in order to get sufficient thickness of tissue, which of course is important to provide the volume of tissue you're talking about. How important is it to trim every bit of epithelium away?
I think it's important. I think it's important because you'll get that tissue surviving, either the potential for creating epithelial cysts or folds in the tissue that will be unaesthetic when you look at it really close up. So I would like to get rid of all the epithelium.
So if you're creating that kind of a bed, you're looking for that kind of thickness, is there a goal to achieve primary closure? In other words, are you elevating a surface flap on the palate and harvesting connective tissue underneath? Or if you can't do that, then you would have a fairly big open wound. Is that just something we have to deal with, or pretty much you're able to do a primary closure in nearly every case? And what happens if you can't? I mean, what happens if you only have 4 millimeters of thickness of tissue and you really can't harvest tissue from that site? Are you then going to go to a perioderm or alloderm or something like that, or how do you deal with lack of donor tissue?
Okay, well, that's a good question. I would like to say that I try to use connective tissue 100% of the time, number one. So what if the patient has a severe need and very little donor tissue to deal with? Well, I might tell that patient on the onset, we might be looking at doing sequential procedures and building up and layering on top of each other. When I'm harvesting the palatal connective tissue, I'm getting the biggest thickness I can, and many times I'll just use the anesthetic syringe to kind of poke around to determine what the tissue thickness is going to be. I never really fold the graft to try to double up on the thickness of it. I don't do that. I don't want to create any dead space. So I'm harvesting the tissue, and I'm not really having a nasty wound on the palate, because the tissue that I've harvested, I'm going to take off the epithelium and I'm going to put it back. And as I showed in that one case where you could see where I harvested the tissue during the procedure and used the liquid suture covered over, that it healed and you couldn't even tell there was any tissue that was harvested from that spot. So I think that we're able to get a good volume of tissue, protect the donor site using the epithelium, the native epithelium that was there, and be able to have a result that tends to be very predictable. And yet, as we all know, that's something that we cringe when a patient has that problem, because we're fraught with dealing with such a small area and a fear that we're not going to be able to get totally successful. But I would argue that point. So, and my staff, who's a lot of them are watching today, would also really agree that it's pretty rare that I go to the tuberosity. I mean, I will go there, but it's usually when I've done a second procedure or patients already had a deficiency of palatal connective tissue. Patients had procedures done before, and I'm seeing the patient for the fourth surgery, and I hadn't seen them for the others before necessarily, but the pond has been drained, so to speak. We don't have a lot of tissue available left. So those are situations I'll look at the tuberosity, but I don't usually make a rule of harvesting that tissue if I can avoid it.
Very good. There's a number of questions. A lot of the questions are the same, so I'll ask it in my own way, since I think 4 out of 6 questions are relate to the same thing, and that is the potential for repocketing in an area where you're restoring a papilla. Is there a new pocket that you're forming when you're doing this kind of restoration?
Well, when we do our root coverage procedures, I'm going to follow a routine where I'm treating the root surface to achieve new attachment. So what I'm doing is I'm demineralizing the root surface with tetracycline. I'm creating a clean root surface, and I would tell you that what's interesting is that even though we're potentially creating a deeper pocket depth, that they've been maintainable. And so I don't really have an issue with pocketing following this type of procedure. Just like with our connective tissue grafting for root coverage, that we usually don't have any significant pocketing at all following that type of procedure. So are we creating new attachment? That's debatable, because I don't have histology to show it. We have other histology from our connective tissue grafts that we can rely on to say that that will happen. But the bottom line is long-term meaning, let's say 23 years follow-up, that we haven't had issues that way where we've had 6 millimeter or 7 millimeter pocket. We don't get it. So, and we're monitoring those patients. It's not like we're doing it and say, okay, bye. And yeah, I do get patients that come from Europe, let's say, or they've heard about me from East Coast and come out to see me, and I don't have the ability to follow them. So what I do have the ability to follow has not had issues.
Very good. That answers nearly every question except one. And this question says, you said you would abort the procedure if the papillary isthmus was torn through during the preparation. What happens if you poke through the attached tissue during while you're creating the partial thickness flap? Is that more forgiving, and would you continue?
No, it's not. And actually, I've never had that happen. In other words, I've never severed the interdental papilla. And I just bring that up because I really want to create caution. I've been teaching the hands-on course for a long time. And I've had it happen where a dentist comes and is taking the course and then is trying to do things at home. And it maybe is a restorative dentist and calling me and saying, okay, what do I do now? Well, it gets really awkward when people get in over their heads. So part of what I'm doing is I'm trying to create a big fear. Do not sever the papilla. And if you do, you could have catastrophic problems if you do. So although I've never done it, I'm trying to emphasize that to the extent that if people do, they can run into problems. And as an aside, in the courses that we've taught at the Newport Coastal Orofacial Institute, that we've had oral surgeons, we've had periodontists, we've had restorative dentists. I mean, John Chow was one of my students. And from that, he decided, I think we can do this connective tissue grafting a little bit differently. and has made a name for himself doing twists that he's done with that. But to get back to the interdental papilla, I just really want to emphasize that if you are so inclined to proceed, I think it's foolhardy to sever the papilla and think you're going to have a good result.
Very good. And the final question is, how does somebody learn how to do this?
Well, I've stopped teaching the hands-on course because it was time consuming and challenging to have patients all the time for that. So I can't really tell you. I used to say, just come take our course, but I'm not really doing that anymore. So I don't have a good answer for that. I'm sorry.
And Dennis Shanna, of course, was teaching microsurgery course. Is there anybody who took his place with regard to that, or did that course stop with him?
No, since Dennis died, Suzanne, his wife, has not continued on with the practice. So no, the Microsurgical Training Institute is no longer.
Very good. I mean, this has been a fantastic presentation, Peter. I can't tell you how well received it is based on the comments that I'm already seeing. And just for all of you out there, Peter has actually volunteered to do at least one more presentation. So we will let you know. We will let you know about that, Peter. I thank you for a marvelous presentation. If there are any questions, just send them on to Peter. You see his email address there. Write to me, and we'll make sure that your questions are answered. Peter, any final words?
Yeah, thank you, Lee. Thank you for the opportunity to be with your group and allow a lot of my friends and restorative people here in San Diego to chime in and participate. Thank you so much. I look at augmentation of the interdental papilla or restoration of the lost interdental papilla as just one of our periodontal procedures. We all kind of hang our hats on our root coverage procedures, but there's other things too. There's our sculpting procedures. A patient that was in just 2 weeks ago came from Egypt. She was, giving me a big hug and really happy and pleased. Those kind of things can be really rewarding as well. Another patient a week ago was basically screaming when we took the dressing off. And Leslie, you recall how fun it is when we take the dressing away and patients see the results of our sculpting. That's our aesthetic crown lengthening. So that, our aesthetic implant placement, I don't think there's another specialty out there that can really do what the periodontist can do. I'm biased, absolutely. But I think that we have a special spot in dentistry to be able to provide aesthetic outcomes where people otherwise think, and dentists many times think, it's not possible to. So I want to encourage the periodontists and restorative dentists out there to look at all of the options available. And I've heard this many times. People attend my regular course and they'll say, well, that's great, you're doing stuff, but my periodontist is not doing that. I would tell the restorative people to interview your periodontist, to ask them their comfort zone, because some people are comfortable doing and predictable root coverage procedures, and others have no predictability at all. And so that's something that the restorative dentist, you have to interview and really identify the team that can give you the kind of outcomes you're looking for. And I know that with Dr. Sheldon and the things that you're doing there in Florida are special, and you're getting things that you can't get other places. So again, I appreciate the opportunity and look forward to the future. Things just keep getting better and better.
They sure do. And you've made this conference better and better. So I thank you, Peter.
Thank you, Lee.
our next conference will be in May. We have not established the date, Doctor, and this is somebody you know who's going to be giving the next one. Peter Bobby Horowitz is going to be giving the next presentation.
Oh yeah,
Yeah.
he's a great guy.
And
He's got so much energy. He's amazing.
that's right. And his comment is, I took the course, meaning taking your course, over 10 years ago, and it changed my practice. That's coming
Nice.
from Bobby to you. Yeah.
Nice. He's a great guy. I love him.
Yes, he is. Thanks all for joining us. Dr. Nordland has kindly allowed us to record this, and I will be posting this. So anybody who's attended this will get the link to this post, and by all means. This is one of those lectures, one of these presentations that should be passed on and on and on, so that people, meaning dentists, even patients, can understand what, and periodontists, of course, can understand what we can do and how we can look at a challenge and meet that challenge and help a lot of patients. So this is a great example of that. Again, Dr. Nordland, thanks for being a part of this. And thanks all of you for joining us tonight. Good night.
Thank you. Thank you very much.